a novel male contraceptive gel and a 6-month female injectable method. He lives in Edinburgh with his husband and two very poorly behaved cats. So please join me in welcoming Dr. John Reynolds-Wright.
Morning, everybody. Thank you very much for the invitation. I'm very glad to be able to join you here in Vancouver as part of Dr. Norman's research team. So I'm very grateful for the invitation to come and join you all. What I am speaking to you about today is the abortion landscape in the UK, and it's quite different from how things are for you. So I'm hoping that you find it interesting. And I'll also go on to speak a little bit about some of the research that we're carrying out. These are just my disclosures in terms of things that I have in terms of funding and other potential conflicts of interest. And yeah, so I'm going to talk you through a little bit about the abortion law in the UK, things that happen for us in terms of fetal anomaly versus quote unquote social indications, and also how some of those services are devised and delivered, including our medical versus surgical abortion workloads. And then I'll talk to you a bit about some of the research stuff that we're doing next. So to start with, UK abortion law, very quickly to begin with, this is a little geography quiz. I don't think anybody on the call online will be able to contribute, but in the room, can anyone point to me the left, middle, or right? Which one of these things is the UK? Wendy might know this because she. Myself from the road. So I've got someone pointing to the left. Which way are you pointing? To the right, yeah. And do you have a guess? On the left one. So congratulations, you're correct. So the most closely resembling the UK is the one on the right-hand side. So well done. You've done your geography lessons. But even then, that's not quite right, because you can see that the Shetland Islands are missing off the top. And also there's loads of other things that are part of the UK that you might not expect to be part of the UK. This is a little map from Encyclopedia Britannica, which tries to explain the differences between things that are the British Isles, United Kingdom, Great Britain, and actually this has got it wrong. So there's things here that they're looping around saying such and such thing, and actually they're not. So don't worry if you didn't guess correctly, because Encyclopedia Britannica doesn't get it right either. The reason why this is important, particularly in relation to abortion law, is that healthcare and healthcare legislation are devolved matters in the UK. And so all of these different sectors of the UK, these constituent nations within it and protectorates and all this kind of stuff that I've listed there, plus loads more that I've not listed, all have got their own healthcare legislation and all have got their own abortion laws. They all start at the same point, because in the past it wasn't always this way, but from that point onwards, as things have diverged, they've all started from the same point, and different bits of legislation then come into place to correct and change things. So this is, which one is this one? This is the UK. And in lots of ways in the UK, Scotland, which is that bit I've just moved over from the top, works differently from the rest of the UK. So I'm going to very briefly explain what happens in Scotland. Abortion law in Scotland, it starts off in something called Scots common law. So this is our traditional laws in Scotland that have been going since like the 1000s, and all these little bits of case law and feudal laws that all get kind of cobbled together into a big kind of messy web called Scots common law. Within there somewhere, it's illegal to have an abortion. And one of the things that's undergoing at the moment with some collaborators we have is they are actually carrying out a research project to work out where in Scottish law abortion is criminalised, because we're not 100% sure. And there's all these little bits of laws that probably, if you had a really close reading of them, could be interpreted as banning abortion. So there's a project going through all of this Scots common law to try and work out which bits we need to try and delete if we were going to decriminalise abortion in Scotland. For the rest of the UK and lots of other places around the world, this lady, does anyone know who this is? Queen Victoria, she signed into law in 1861 the Offences Against the Person Act. And this is the piece of legislation that for the rest of the UK and lots of other bits of our protectorates and stuff bans abortion in all circumstances. I'm going to explain it to you a little bit more detail, but 1861 is quite a long time ago. This was about 8 years before the Catholic Church formally started opposing abortion. So that didn't really start happening until 1869. It's also about 5-6 years before Queen Victoria signed the legislation that created the Dominion of Canada. So the current formulation that you have as Canada, the legislation that she signed to create that is younger than our abortion legislation in the UK. So that's how old and outdated this piece of legislation is. And this, we have a website in the UK called legislation.gov.uk, which shows all of the live laws, all the laws that are applicable in the UK at any given time. It shows them up. Sorry, this is showing up a little bit small on the screen in the room, but the bits that we're interested in relation to the abortion law is the subsection attempts to procure abortion, sections 58 and 59. And these are the bits that criminalize abortion. But as you can see, the reason I show this slide, it's got all sorts of weird things in it, the Offences Against the Person Act. So child stealing, bigamy, concealing the birth of a child, making gunpowder. These things are all together in the same piece of legislation. And, you know, here we've got offences committed under the Admiralty. So again, we have these little bits of laws that are all kind of mushed together in this bizarre piece of legislation. All of these sections that are little dots, these are all areas of this act that have been subsequently deleted and now irrelevant. So when you go and click on it, it just says this has now been deleted or it's been superseded by other legislation. And the reason why, again, I think that's very important to highlight is that this act, this piece of legislation, is not the foundation upon which law and order stands in the UK. It is been deleted in other ways, it's been updated, it's been replaced, all different sections of it. So it is definitely feasible and realistic for us to delete or replace this piece of legislation. So why is it such a big deal? Why does it matter that we have this legislation that bans abortion? Well, we have this first section that says is about administering drugs. So this is either a woman using medicines or instruments to procure her own abortion, or somebody like me doing it for them. And the second section is about even buying drugs or supplying drugs or equipment that might reasonably be used to commit an abortion. Both of these things are criminalized. And here highlighted in red is what the real problem is, that you can be kept in penal servitude for life if you have been found to do this. So if I commit an abortion, I could go to prison forever. And likewise, any person that I treat might have that. And if anybody even sells me abortion equipment, they can go to prison for some indeterminate period of time. So in England and Wales, this legislation is what currently actually still stands today. And we've gone through this very sort of convoluted legal process to kind of get around this, which I'll briefly outline now. So that happened in 1861. And things kind of continued to get worse from that point onwards. We can see here in the sort of first half of the 20th century, in 1920s, 15% of all maternal deaths in the UK were attributable to unsafe abortion, which is a huge amount for at the time, the country that ruled the world, essentially. It was insane. It was completely unacceptable. And in the 30s, increasingly public conscience and public concern was evident about these rising numbers of deaths related to abortion, the morbidity that went with them. Everybody knew somebody who died from having an abortion. Even if we didn't talk about it in that way, we would know that someone had had a heavy bleed or they couldn't have children, something like that. In 1934, the Conference of Cooperative Women, which is like a union labour movement amongst women in the UK, passed the resolution to that its formal stance, and which permeated out into the rest of the labour movement in the UK, was that abortion should be decriminalised. It should no longer be banned. And following on from that, in 1936, the Abortion Law Reform Association, which was a critical lobbying and legal organisation, was formed, which really helped advance us towards having legal abortion in the UK. And then in 1938, Dr. Alex Bourne was acquitted of committing an abortion under the Offences Against the Person Act. And this was a really important piece of legal precedence, because in the Act, it doesn't make any provision for rape, incest, anything like that you might typically hear about or think about would be even within some of the extreme abortion bans in the United States. And this doctor performed an abortion for a 14-year-old girl who'd been violently gang raped and was suicidal and all these kind of things, and committed the abortion and then confessed to it, and actually went to court and was found to be not guilty in court. And so that again set like an important precedent at that time. And there was building momentum towards public opinion and legal reform around abortion to decriminalise it. And then the next year, pesky thing, World War II happened, which then really kind of scuppered all movements for the next kind of 10 years or so. It really added another decade onto our movement forward with this. And then in 1967, it must have been a little bit before then, probably 1966, a private member's bill was brought forward by Liberal MP David Steele. So a private member's bill is something that any member of parliament in the UK can put forward a bill, and it can get voted on to then be debated in the House of Commons and then voted on and written into law. And really importantly, these laws are bills, they're not whipped. So again, I don't know if you use this expression in Canada in your parliament, but when our party leaders will whip their members into voting in a certain way. But private members' bills traditionally are not whipped, and also ever since this piece of legislation went through Parliament, every subsequent abortion legislation has not been whipped since. And again, this sets an important piece of precedence because people are allowed to vote in line with their conscience, in line with what their constituents might want, rather than what the government says or what the party leadership says they should vote in. This was really, really hard for, and it's a very compromised piece of legislation, which you'll see in a moment. But people from the Abortion Law Reform Association talk about working on this and working literally through the night to up until the last minute when the votes were going in, brokering, making deals, making exchanges in order to get this legislation through so that we had something at the end of the day. And I think they all really recognize, this was supposed to be a starting point and not a finishing point. And here we are more than 50 years later with the same piece of legislation. And what this act does is it exempts people like me and people that I treat from being prosecuted under the Offences Against the Person Act, or in Scotland under the whatever bit of Scots law and common law tells me that I'm not allowed to do it, as long as we meet the criteria that are set out within this act. So we've got very stringent, specific criteria that we have to meet in order to be able to provide abortions. And that's absolute. And if you colour outside the lines, if you do it with the recommendations of the 1967 Abortion Act, you were then subject to the 1861 Offences Against the Person Act still. So that's why it's really important to understand how all this fits together. What I've included there, the little QR code on the link, is a film, Kind to Women. It's free. You can just log on and watch it, I think, anywhere. And it's called Kind to Women. And there's a couple of different ones. So there's one called Knitting Needle Nora, which is about the backstreet abortionists that we used to have in the UK. And they were often referred to as Knitting Needle Noras because the sort of imagery that you have in sort of North America is around the coat hanger. For us, it's the knitting needle. Is what people used to use to illegally procure abortions. Unsafe abortions. But then there's another video on there as well that's called Kind to Women, and this is all straight to camera discussions with the people who made this happen. So the people who were in the Abortion Law Reform Association, David Steele, the MP that made it go through, and doctors and nurses who worked before and after the abortion legislation, women who'd had abortions in illegal times, women who'd had their children taken away from them, all this kind of stuff. And it's a really fantastic documentary. It's only 38 minutes and it's really, really informative about that time. And it's really important, I think, because we don't see it anymore in the UK. We don't see all these women turning up at the weekend bleeding out because they've had an illegal abortion. And it really is, I think, important for reminding everyone why we need this change and why the work that we do is so important. So again, apologies to those in the room. This is a little bit distant to see, but this is the certificate, the Abortion Act certificate that I have to fill out every time that I do an abortion. And it's not just me that fills it out because it has to be done by 2 different doctors. So they have to be doctors that fill this out. And you have up at the top here, so it says, I, so-and-so of such and such a place, have or have not seen and or examined the pregnant woman to whom the certificate relates at such and such a place on such and such a date. So there's one person there and a second person there. Then say, we hereby certify that we are formed in the opinion, formed in good faith, and that's a really important piece of the wording, is in good faith, that the case of such and such a person meets the criteria of the Abortion Act. And again, this is the only piece of healthcare that's treated like this in the UK. And everybody that has an abortion is reportable by name, date of birth, and address to the Secretary of State. So the Secretary of State knows everybody that has all these abortions. They are not interested. They do not want to see this. And so we have a very kind of, again, convoluted process by which we send it to them, and then they delegate that responsibility to the medical officer, and then they chop it up so that actually it's not very identifiable. But technically, within the auspices of the law, this is not a confidential part of healthcare, unlike every other bit of healthcare that takes place. And just to zoom in, these are the clauses that we have to choose from, so A through to E. And in practice, we only really use C and E. And C is the one for quote unquote social terminations. E is for fetal anomaly terminations. And the really important bit of difference between those two things is that there is a time limit baked into clause C, 24 weeks. And then in clause E, there is no time limit for that, which is, I think, an important and a positive part, at least for fetal anomaly care, because it gives people time to choose, it gives people time to reflect, it gives them more options about what they might want to do for their pregnancies. I'll come back to that in a moment. Now, there's pros and cons to this. Obviously, having a threat of criminal law sat over the top of us is quite anxiety-provoking for a lot of people. It's perhaps part of the reason why lots of mainstream obstetrics and gynecology doctors do not get involved in abortion care, because there is this kind of weird bit of legality that doesn't really apply in other areas of their practice and their other areas of medicine. We don't technically have abortion on demand, although really, and again, this is something that you see if you watch that documentary, particularly in the past, these doctors were sort of hip to the idea of what this legislation was, is we're basically giving anybody an abortion that wants it. We just have to make it fit into whatever category we can tick the box. But we don't, I've never ever said no to somebody to have an abortion. There are some very specific things that there's additional laws that are written around sex selection for fetal, for abortion. Is it specifically documented as being something that we're not allowed to do? So if somebody turns up and says that they want to do that, we have to tell them, I'm afraid, we can't do that. Again, it happens very, very infrequently. And almost always when it happens, you start thinking, is this a journalist that's trying to catch us out? Because that's happened on a few different times in different places in the UK. Sort of anti-choice journalists turning up and doing a sting. So it's, of course, paternalistic. It's heavily gendered. It's all that kind of stuff. But the good thing is that this is not a two-tier system. Everyone is in the same boat from a legislative point of view. And when you contrast it with most other countries in Europe, there's usually an abortion on demand up to maybe 12 or 14 weeks. And beyond that, in theory, you could get an abortion for whatever reason, distress, financial, mental health, blah, blah, blah. But it becomes a lot more restrictive and a lot more difficult to access abortion beyond that first kind of tier of abortion on demand. And actually in the UK, we don't have any of that. Like, there are service pressures and delivery pressures that make it difficult sometimes for people to access abortions. But the law bit of it is not usually one of them. And we shield our patients quite a lot from this legal burden. And that most patients don't really realise that this is what's happening. And lots of people in the UK don't actually realise, including some of our politicians, don't realise that this is the situation, that we have this 1800s law governing what we do. And we also have a later overall gestation for social indications than many other European countries. And we do see women travel to the UK for care from neighbouring countries. So France, Poland particularly, Eastern Europe might come and see us for care. And yeah, that's what I was going to say about that. Now, again, there's lots of problems still with this law, particularly in the last few years, since telemedicine has meant that we may not actually see women in person. And one of the risks that happens about 0.4% of the time when you do an abortion by telemedicine is you will get the gestation wrong, or the woman will get the gestation wrong. And so we've had in the last year a slew of headlines that look like this about women being prosecuted under this law, people being investigated under these laws, and stuff like having a stillbirth and then being investigated and held for an suspicion of an illegal abortion is the sort of thing that you read about in Texas. And it's not, and we're having it in the UK as well. People are outraged, and quite rightly so. And I think we're at quite a interesting and critical time where I'm hoping that we will get some momentum behind decriminalisation, because of actually the outrage over these recent cases of women who have been in extremis, then being subjected to these really kind of horrible, violent investigations, being pinned against the floor and dragged out of their home while their children watch, all this kind of stuff. It's been really, really awful in the last sort of 12 months, but I'm hoping that we're going to get a silver lining, at least, from all of this stuff. And then there's been some other little bits of legal changes. I promise it's the last bit of the law to tell you about. I know it's not super exciting. In 2017, we were allowed to give people misoprostol to use at home. So in the UK, we've had mifepristone and misoprostol for abortion since before 2000. So for years and years and years, we've been using it. However, because of the Abortion Act states that you must have your abortion treatment in a licensed premises, medical abortion for people at very early gestations, the process used to be that you had to come in for one day, take your mifepristone in clinic while we watched, you went home, you came back 1 to 2 days later, then you took your misoprostol in clinic while we watched, and then you dashed home so that you hopefully didn't deliver on the bus, in the taxi, and you ran home and then had your abortion at home, if we didn't book you into a hospital, which is crazy. And so only in 2017, and this kind of happened in a ripple effect across the UK, again, remembering that it's all different in the laws. So in Scotland first, we put in the legislation to allow misoprostol at home, and then swiftly followed by England and Wales. And so then when we were able to have the mifepristone in the clinic, we still had to watch them, and then we could send them home and they could have the medicines at home without risk of any bleeding on public transport and things like that. Chronologically, the next thing that happened in 2019 was the Northern Ireland Executive Formation Act. So Northern Ireland, another bit of the UK with its own laws, they never had the 1967 Act. So right up until 2019, they only had the 1861 Offence Against the Person Act. So abortion in Northern Ireland was criminalised in all circumstances, totally. So we saw lots of women in the mainland UK and Great Britain coming from there to have treatment at their own cost. It was a real bad situation for women that lived in that country. And with all of these things, they had this, since kind of 2017, they've had a really fractious government. It's a sort of very right-wing, homophobic, anti-abortion government, all this kind of stuff, and very factional, lots of different, no majority government, or lots of infighting. And basically they had a non-functioning government for at least a 12-month period when just nothing was happening. Laws were not getting passed, work was not being done, all this kind of stuff. So Westminster had to put in place some direct rule to basically say, we need to get all of this admin done. We need to have these bills passed, blah, blah, blah. So we're just going to do it for you and impose it directly, which they have the power to do. And as part of that, two Labour MPs, Stella Creasy and Diana Johnson, were able to amend this and get an amendment passed that, as part of this piece of legislation, deleted the Offences Against the Person Act, clause 58 and 59 for Northern Ireland. So overnight, when this passed, Northern Ireland went from having probably the most restrictive abortion law in the world to having no abortion law at all of a sudden. And so we were able to deliver their abortion care by telemedicine, all this kind of stuff. Subsequent to that, there's been additional restrictions kind of put in place, but it's in a much better place than it used to be. And then back in Great Britain, in COVID, when COVID hit, we got this temporary permission for us to then actually give people mifepristone at home. And mifepristone at home meant that actually we could let people have telemedicine and no-touch abortion for the first time. We didn't need to bring them in for ultrasound scans. We could send them their packs. They could come collect their packs. We could post things to them. They could do all their treatment at home on their own schedules. So that was fantastic, but it was all tied up in the COVID legislation across the different areas. And then eventually, a couple of years later, I think in 2021, going into 2022, this finally got made permanent, first in England, then in Wales, and then in Scotland. So hopefully not bore you all rigid with the legal situation. And I think the reason I spent so much time talking about it and underlining is this permeates everything that we do. Any innovation, any delivery of service is all totally influenced by what our restriction and this stranglehold that the law has over us. And I'm now going to talk you through some of the kind of practicalities that we have and some of the epidemiology, a little bit of what we have for different forms of care in the UK. So starting off with our kind of clause C versus clause E, which is our abortion on request, social indication abortion versus fetal anomaly indications. So as I said, clause C is the one that's most broadly used for sort of the social indications. And within it, even though we have to adhere to this quite strictly, as you read it, it's quite vague and it is deliberately vague. As long as it's not exceeded its 24th week, but that continuing the pregnancy would involve more risk than having an abortion, a physical or mental injury to the pregnant woman. That's really vague. And actually you can always justify this. I always tell our trainees and our students, you can always justify this because we know it's safer to have an abortion at any gestation than it is to have a term delivery. So you can always tick clause C. You can always get people through for that care that way. And that's what 90%, 98% of the abortions in the UK are performed under. In Scotland and England and Wales, it's all pretty similar across the board. For clause E for fetal anomaly, again, deliberately vague. If you have the substantial risk, so a real risk, not even a confirmation, but a real risk that the child would suffer from a physical or mental abnormalities as to be seriously handicapped. Again, extremely vague. It's deliberately vague to give people latitude, to let people make choices that's right for them, right for their families as well. About 1.8% of abortions are performed under this. And then the remaining 0.2% are where people have ticked one of the other things. And we don't really know why people tick the other things. It doesn't matter. But the convention is that we tend to use clause C or clause E. Clause C abortions, again, we treat them differently because, again, we treat women who are choosing to end in pregnancy for social reasons differently from how we treat women who have fetal indications, which is maybe true everywhere in the world. We provide these in a variety of settings, particularly in England and Wales. Most of these are provided in the independent sector. So these are charitable organisations, the British Pregnancy Advisory Service, Mary Stopes International, that have freestanding clinics at various points around the country. They're high volume, highly concentrated, a combination of medical, surgical at varying gestations. The second one, the community sexual and reproductive health services, are within the NHS, and that's the setting that I work in. So we work out in the community in a freestanding clinic that's not a hospital, but we deliver all the abortion services for our region, mostly by medical methods, but we also refer people in for the surgical and the later medicals if they need it to be done. And then some places it's still run by a hospital gynaecology outpatient department. So the Kingdom of Fife, which is the bit across the river from where Edinburgh is, that's all still run by the inpatient services there. Now, clause E, by contrast, are performed almost exclusively by a hospital obstetric and gynecology services, and they're almost universally using medical methods, so induction methods of abortion. Very small numbers of services around the country offer surgical services, and very few offer any choice between medical and surgical methods, like a true choice. To talk a little bit more about how those services are devised, again, it varies across the different nations. So Scotland, we almost exclusively provide NHS abortions, almost exclusively using medication, so mifepristone, misoprostol. And we unfortunately, even though our legal limit is still 24 weeks, we have not got any services that provide over 20 weeks for social indications. Now, for clause E, for fetal anomaly, we do, but those people that provide those refuse to do it for social indications. And as it stands at the moment, I'm the only person in Scotland that's trained to do D&E between 20 and 24 weeks, which again is not a very, I don't say that to boast, it's just to illustrate that that is the situation we're in terms of service provision and skill set within the country. In Wales, under 12 weeks is almost all provided by the NHS, and then over 12 weeks, almost all provided by independent sector. And then in England, almost all of them, so more than 2/3, are provided by the independent sector under an NHS contract. So this means that it's still free at the point of access for patients. When they go in and they get their abortion care, they're not paying anybody anything, but it is not done by an NHS facility when they're actually receiving that care. And because those are charitable organisations, freestanding clinics, they do not set up to support people with complex medical needs. So they have this evolving complex medical needs network across the UK that allow the independent sector, who almost always assess everybody, to then refer inwards to get these women care in a high acuity obstetric and gynaecology centres. And those are dotted all around the UK. So here in England and Wales, this again, doesn't show up brilliantly in the room, but this kind of dark purple is the abortions that have been performed in an NHS hospital and funded by the NHS. This lighter purple, I don't know why whoever made this graph made it all in purple, shades purple, it's not a great idea. This lighter shade of purple in the middle is NHS funded, but in an independent sector provider. And then this top shade of purple is about people that pay privately. And this along the bottom is every year since 1981 going through till 2021. And you can see it used to be pretty much 50-50 between people paying privately to go to places like British Pregnancy Advisory Service and 50% having NHS care. And as time's gone on, there's this explosion of care taking place in the independent sector under NHS contract. So by the time we hit 2021, again, that's where we get to that kind of 70-30 split in terms of where these are being performed. And this tiny number of people having privately paid for abortions are predominantly people coming from overseas who are not, who don't have recourse to NHS funding. Or they might be people, I've seen this once or twice, people who find whatever the local service set up in their area of the UK unacceptable and have the means to go and pay for care somewhere else, they might choose to do that. But they represent a very, very small number of people. And this map on the other side, sorry, is a map of all of the places that I went to in the British Pregnancy Advisory Service in the sector, independent sector provider, when I went to go and train to do D&E and surgical abortion. So I was shooting around all the parts of the country where those little crosses are. And these are all different freestanding clinics. They have a clinic in Liverpool, a clinic in Doncaster, and a clinic in London. Those are the ones that go and deal with the later gestation ones. But the clinics here in Birmingham and in Bournemouth also deal with up to 18 and 6 under contraception. And this is, again, just a little bit of the epidemiology of abortion care and what's going on in England and Wales. Because, again, of the differences between England, Wales and Scotland, we report all of our statistics independently, which sometimes makes it very difficult to explain exactly what's going on overall. But as time's gone on, we found that our under 18 group has the percentage in the proportion of people receiving abortion care, the crude abortion rate is falling in that group. And there's been a lot of work to try and reduce teenage pregnancy, all kinds of teenage pregnancy, and to support people to make healthy choices and access contraception. But at the same time, we see this gradual increase in the group who are having abortions over the age of 35. And is that to do with, there's lots of different kind of sociological factors. Is it the time when people start getting divorced and then they start going and meeting new partners and then forgetting about all the things they need to do to prevent pregnancy and then falling pregnant? Is it, this is the time where people are getting tired of using hormones and using contraception for their life, and so they take a break, or they think they can't get pregnant anymore, or they think they're menopausal, and lo and behold, they've managed to get pregnant. So we have this kind of slow and steady increase. And just as we've done lots of work to try and widen access to sexual and reproductive health services for people under the age of 18, we're not really very good at making sure that those services are accessible in the same way for people that are older, but still in their fertile window. This is just a breakdown on kind of ethnic lines. Asian or British Asian in the UK means South Asian rather than East Asian, and that's why Chinese other is the kind of category that captures people from Chinese backgrounds and other ethnic backgrounds. And the breakdown that you can see here, 78% white, and the different breakdowns that you see there, that's broadly reflective actually of the UK population as a whole. We know that people from Black backgrounds, the various kind of Black, African and Caribbean backgrounds, are more likely to be overrepresented in the groups that have more than one abortion. But in terms of this kind of crude overall rate of people accessing care, this is broadly reflective of what the UK is like on a racial basis. Now, looking at Scotland, this again is Scotland rather than any of the other combinations that you might see, and actually is missing bits of Scotland because Orkney is up here and then Shetland's even further up north off the screen. But these are the different health boards. So you might see here, these are the kind of organisational units of how healthcare is delivered in Scotland. And this is NHS Highland. So all of this bit here is all one health board. And it's nearly 50% of the size of Scotland, and it's got a fraction of the people that live in Scotland. Where this little orange bar is where 80% of people in Scotland live. And this health board here, Lothian, is where I live and work. And then this is Glasgow, is this other sort of dark blue. And Glasgow actually probably has about half of the people in Scotland. 2/3 of people of Scotland live in this tiny little area here. And so one of the things I wanted to show to you was about rurality. Again, I apologize to the people in the room for how small this looks, but we have this bar here that shows so this graph is all about people that receive abortion care under 9 weeks of gestation. And this is our kind of proxy for access and accessibility. And you can see that overall, the rest of Scotland and those that live in accessible rural areas, we're getting about kind of 75, 80% of abortions are performed under 9 weeks gestation. And not far behind, probably just more closer to the 70% mark, those that live in remote rural areas are also able to access this under 9 weeks gestation. But you can see that there is a definite difference between those different things. You'll probably laugh at our definition of what remote rural is. It basically means anybody that lives in a settlement of less than 3,000 people that is more than 30 minutes drive away from a settlement of 10,000 people or more. So it's not exactly like being up on one of the islands that you have in the far north of BC, where it's like a 2-day hike to get to anything, to the nearest pharmacy or whatever. But we do see, even in our relatively small country, that this element of rurality influences care and influences access. And you can also see that we've had this slow increase in Scotland, and this is reflected in the UK data of the abortion rate, a little bit of a slow increase. And then in the last couple of years, we've had this sort of uptick and this kind of hangover from after COVID, where our services, our healthcare services are absolutely decimated and are falling to pieces, really. And this goes up again. The data are not ready yet for 2023, but I know it jumps up further when it comes to 2023. We've seen in our own service an increase of 40% in referrals between 2023 and 2022. And a lot of that is probably to do with difficult access to general practice in the UK, because general practitioners are really on their knees at the moment and have got really difficult access to providing care. And then there's also this background of kind of the anti-hormone movement that's taking place through social media at the moment, which I think is a strong contributing factor at the moment for younger people. And so to just kind of talk a little bit more about the medical versus surgical, and I know that the terminology here is usually medication versus procedural. So this is again data from England and Wales over the past kind of like year or so. This dark blue band, 10%, is all of our surgical abortions for England and Wales. And this is including vacuum aspiration procedures in the first trimester, dilatation evacuation procedures in the second trimester, amounts to about 10-ish% overall. These two colourful bars here, these are all pregnancies that are under 10 weeks in England and Wales, and that are passing the pregnancy at home. So people that are having an early medical abortion, whether they've had the mifepristone in the clinic and then taken the misoprostol home, or whether they've taken both medicines at home. Our legislators are very obsessed with this idea that people should still be given the choice of having mifepristone in clinic. Who knows why? It's something that they're very keen on, and they want us to record it and know how many people we're doing that for. I don't really know why. So that's something that we record fervently. And then this last little bar at the moment, so maybe 8% of cases in sort of April to June 2022. This is all about inpatient medical procedures. It might be some at home. So this is where mifepristone and misoprostol have been given in a clinical facility. Nowadays, it's really rare to be doing an early medical abortion at home, having both medicines in clinic. It's almost never happens now. So these probably represent people having medical abortions in a facility for whatever reason. So that's the kind of breakdown in England and Wales. When you look at Scotland, by contrast, so this top line here is this is the dark blue line is the percentage of abortions that are under 9 weeks and performed using medical methods. So we're looking at kind of 95, 96% in Scotland. It's a little bit higher in 2023, although that data is not published yet. And the percentage in the light blue line of all of them that are medical. As you can see, once we hit 2020, there basically becomes no difference. Our access to surgical abortion, limited as it was prior to COVID-19, is essentially gone. So we only really can offer people medical abortions, and rarely we're able to offer them a surgical abortion in the first trimester if they really want one. And if you contrast this to England and Wales, you can see that, again, all methods under 9 weeks are medical. So again, pretty close to what we're doing. So around about the 90% mark for those under 9 weeks. And then overall, we're sort of sat at that kind of 85-ish% for all of the terminations overall that were actually medical. So I think that's quite a different pattern to how things are in Canada in terms of our proportion of medical. And there's it's a double-edged sword. I think there's a lot of positives, particularly in those really early gestations, and getting more people down to those early gestations by having really readily accessible services and readily accessible medication abortion gets people down under 9 weeks. It gets them having nice, safe, early medical abortions that they can do in the comforts of their own home. But the contrast to that is that it then means that our surgical services contract. People become less confident and willing to perform surgical procedures. And so we really need to strategize about how we're going to redevelop and resustain that. And so, yeah, that's basically just summarizing a little bit of what I've said before. So medical abortion in Scotland, up to 12 weeks at home, slightly different legislative framework between England and Wales. Again, they can only do that up to 10 weeks having their treatment at home. We're allowed to do up to 12 weeks in line with the WHO recommendations. And then between 12 and 20 weeks, we do the medical abortions in hospital, social indications, and then we will then send people down to England if we have to beyond that. And usually almost everywhere now, it's except for some of the smaller health board setups, almost all of the initial assessment is done with telemedicine and should then have a selective use of ultrasound. We have a pro forma that determines whether or not we need to use ultrasound, signs and symptoms of an ectopic pregnancy, unclear gestation, uncertain gestation will let us decide whether or not we need to do an ultrasound scan. But as I've said, surgical abortion access heavily restricted, almost always done, excuse me, by electrovacuum aspiration under general anaesthetics in hospital units. And many places have got either no provision per week or 1 or 2 slots per week. We're quite lucky in Lothian in that we have 3 or 4 per week, but that's like how much we can get away with. So I now just wanted to talk a little bit about some of the work that we've done to develop and expand abortion care over the last couple of years. And really the main thing that I've been involved in relation to this is telemedicine development. And this really took off for us during COVID-19. We had this legislative change that gave us the opportunity to take these steps forward and provide care in this new way with a new model. As I alluded to before, excuse me, the home use of these medicines is allowed in Scotland up to 12 weeks, but only 10 weeks in England and Wales. And we have national body guidelines, so RCOG, so the Royal College of Obstetricians and Gynaecologists, the Faculty of Sexual and Reproductive Health, to which I belong, the British Society of Abortion Care Providers, again, which is something that I belong to, and the Royal College of Midwives all co-signed this piece of guidance that really strongly advocated for the selective use of ultrasound and to use telemedicine, no test, medication abortion wherever possible during COVID-19. And this is our patient journey that takes place in Edinburgh. So if you were going to come and have an abortion in Edinburgh, the person calls up to the booking line for an appointment, and we arrange an appointment ideally within 48 hours. And sometimes during COVID, when we had not a lot of other things to do, we were able to see people the same day for their telemedicine callback. So they would get called back by a clinician who establishes their gestation, their past medical history, what future contraceptive method they want to use. They do a safeguarding assessment, and they talk about the choice of method that they would want for their abortion, and determine whether or not they need to have an inpatient appointment visit. So do they need an ultrasound scan? When
listeners might not know safeguarding. It's not
oh, sorry.
Yeah.
So safeguarding is about screening for domestic violence and anything really, substance misuse, homelessness, all things like that. So making sure that people are safe at home if they're going to go do this abortion at home. If they need to have an ultrasound and we determine that's needed, then we book an in-person appointment. And then they can go on to get their medications, and we can either courier these out. We had collection points where people can come and get it from our clinic. It was kind of like passing a bag out through a window, so we did it in our clinic. I know that up in Grampian, up in the north near Aberdeen, they had some pharmacy hubs that they'd paired up with, where they would send the packs out, and then when we could go up to the pharmacy hub and grab the medicine. In the west of Scotland, in the Western Isles, there was one little postman that used to go out and then leave the medicines in a place, and then the women could come get them because everyone knows everyone there, because it's only like 200 people live in that area. So to hide who they were, they would go and get done in that way. So people come and get their medicines, and then they get their treatment at home. Now we give people for their medicines, we give them mifepristone 200 milligrams, and then we give everybody under 10 weeks gets 800 micrograms of misoprostol, and we also give them another another 400 micrograms of misoprostol just in case, to take 3 to 4 hours later if they've not started bleeding or getting pain yet, just to kind of give them another kind of kick towards passing the pregnancy. And in the gestation between 10 and 12 weeks, we would give them another 1 to 2 doses as well to use, just to kind of really G them along and let them pass the pregnancy if they needed to. When we assessed this, I'll present some of the results in a minute, but when we assessed that bit, we found that basically no one needed to use those additional doses. Everybody completed with 800 or 800 plus 400, and the additional doses at that slightly higher gestation were not really needed very often. And then in terms of assessment, and this is something that I've learned coming to various different clinics that I've been very fortunate to come and visit, Willow Clinic, Elizabeth Bagshaw. There's a lot of time spent in a medical abortion care here, contacting women afterwards to do their follow-up and check that the pregnancy is completed. And actually we pass this over to patients, and we use what we call a low sensitivity urinary pregnancy test. So this is a HCG urine pregnancy test that turns positive only over 1,000 units of HCG, and it's validated for confirming completion of medical abortion at 2 weeks following on from misoprostol. And that is what we use as our default. And we have done for a long time, and found that it's very successful at screening for people who've still got continuing pregnancies. And so we give these patients these pregnancy tests to do, and then they can contact us if they're getting problematic bleeding or some other problem. They can get in contact. If they have a positive or invalid test, they're directed to contact us. If they've got signs of continuing pregnancy, failure of the procedure, all this kind of stuff, they might contact us before then. And if it's negative at that point and their symptoms are resolved, they've bled appropriately, then their abortion's complete and they can begin their contraception. And if we need to assess them clinically, we can call them in and do whatever we need to do for them after that. So we've written up this project, this clinical framework that we've developed in several different places. And this study up at the top is the one that's kind of the primary study really for looking at this, and the sort of linchpin for the other things that we've done. And I'll just briefly outline some of the results for this. So this was our study period. So really from the heart of COVID-19. So the legislative changes that took place that let us have mifepristone and misoprostol at home, they happened on the 31st of March 2020, and the next day we reformatted our clinic and started doing telemedicine. So we were really ready to go when that happened. And during this sort of 3.5, 4 month period, we had about 800 women contacting the service, and of those, 663 women went on to have a medical abortion at home under 12 weeks. You can see the breakdown of other options there. So about 11% went on to have other kinds of abortion, and then the remaining women either decide to continue their pregnancy, because we do get that. We get people who panic, they call us, they have a counselling session and then decide to continue, people whose pregnancies ended in miscarriage, people who we lost track of. And actually you can see we only lost track of 0.2%, so 2 cases out of 663, and that's by virtue of the 2 cases out of 826, actually, sorry, not 663. And that's because of the way that our healthcare system is devised in the region. We are a monopoly provider of healthcare, and we in the Chalmers Centre are a monopoly provider of abortion care. And so we are able to access their medical records both from our service and from the regional electronic health service. And we have a relatively static population in Scotland, and people kind of maybe move around in their health board areas, but they rarely leave their health board areas, particularly at this time, because they were legally not allowed to. So we were able to get really, really good follow-up rates and work out what was going on for people in the study. And so this is just kind of the headline. So 98% success for the abortion. We only had 9 failed abortions, and only 5 that were just continuing pregnancies and 4 that were incomplete abortions requiring surgical intervention. And of the 9, 8 of them were at less than 10 weeks gestation. One of the kind of anxieties was, oh God, we're pushing our limit between 10 and 12 weeks. And actually only one of them was within that time frame. Most of the ones that failed were actually less than that. But they represent a small number overall. 2 women chose not to use the medicine, which again is a good thing. I think it puts the medicines in their hands and it lets them and empowers them the decision to make it and to own that decision. And these women own that decision by not taking the medicine. One was a presumed caesarean scar ectopic. It was never confirmed histologically. And again, something that people get panicked around with ectopic pregnancies. This was somebody who was screened in for having an ultrasound scan. So again, our protocols detected this risk, brought her in, scanned her, initially thought she had an intrauterine pregnancy, treated her, and then came back, and we sort of then saw this sac kind of dangling down, adhered to the previous cesarean section. And so she then went on to have methotrexate and was made a full recovery. And then one person who was not pregnant, and this does happen from time to time, where again with telemedicine, people tell us they've had a positive pregnancy test. We gave her a medicine. She took the mifepristone misoprostol, absolutely no bleeding, came back in day 1 after she had her misoprostol, had a blood HCG done, and it was 0. So she just would not have been pregnant in the first place in that scenario. So she's had a false positive pregnancy test in the community. So that happens, and it's not the end of the world. In terms of complications and unscheduled contact, again, this is something that we were quite interested in how it might impact on our service delivery. We had absolutely no further contact from 79% of the women that went through the service. So they had their treatment, they got on okay, and then they left. And then we broke down the remaining attendances into telephone contact only. So we have a line that is staffed for any questions all the time during the day, and then overnight they might get contact the ward, but they're directed to, unless it's an emergency, they're directed to kind of save their questions for the specialist nurse in the clinic to answer their phone. And that was about 10% of the contacts were just telephone advice only, people calling up saying, have I done this right? This has happened, does that sound okay? Yeah, great, okay, carry on. Then we had another 10% who actually had an in-person attendance, and most of those were actually planned clinic return visits. So maybe they had a positive pregnancy test, they need to come in for a scan, they might have wanted to come back in for contraception, for a LARC insertion. So these kind of planned reattendances were the next kind of highest group, and very small numbers of people attending out of hours or for an emergency attendance, so about 1%, which is similar to what we've had in previous studies. And in our previous studies, we have here on the left what used to happen when we gave people both medicines in clinic, so clinic misoprostol as well as clinic mifepristone. Then we've got home misoprostol but clinic mifepristone beforehand, and this is where we gave both medicines away for people to use at home. And we're not quite comparing apples with apples on this one because we didn't have this breakdown of telephone contact only. So we have got the telephone contact, the different types of in-person attendance. So for telephone contact only afterwards, it's a comparable rate of telephone contact across all 3 of these categories. Even when we gave everybody their medicine and we did it for them in clinic, we still had 10% of people, 9.5% of people calling us afterwards asking about things. When it comes to the in-person attendances, it looks like there's a dramatic increase when we move to telemedicine, but that's because in the clinic and the home misoprostol categorization, these were emergency attendances. They weren't just any planned reattendance. And so when you split the telemedicine group into emergency or planned reattendance, you actually see that the 2.4% is kind of similar to the 2.7% when it was just misoprostol at home. And this kind of planned reattendance was kind of a new emerging category in the way that we were collecting and reporting on our data. I'm conscious of time, so I'll just wrap up. The features of a perfect service was what was something we asked everybody as part of this work and part of the follow-up. We asked them, what would you like to see from an abortion service going forward? What do you want to see? And it's a little bit small, so you maybe just have to trust me, but in the reds here, we've got things that people only sort of 20-25% of people rated as being important to them in a future service. And so that's having an ultrasound scan. Only 26% of people said that having an ultrasound scan was important to them going forwards. And having a video consultation, which was kind of all the rage in the UK at the time of COVID. I don't know if that was the same case here. People loved the idea of having 18% of people wanted to have a video consultation. All of our telemedicine contacts were by normal telephone. So again, that's not something that we've invested in going forwards. But the stuff that we're interested in is these things where actually over 60% of people have said that it's important to them for their care going forward. So a mobile phone app to send and receive information in advance. We're working at the moment to get that built into our clinic facility. Online booking, that's a little bit more tricky in the way that our service is devised. So as nice as that would be, that's something that's a little bit on the back burner. Medication posted to me is something, again, that we are looking at and working at. It's a little bit tricky because of the sort of contracts that are in place for how we get the medications prepped and packed and things. At the moment, it's still in-house, but we have couriered things to people before, and it's something that we've definitely got an eye on for the future. And then the final thing is medication that could be collected from a local pharmacy, which is actually more kind of popular than having it by post. And that's something that's leading on to a little bit of work that we're going to do going forwards. So just to really finish off, I'll tell you briefly about the SHARP project. So this is a pilot that I'm working on at the moment and setting up, getting 3 community pharmacies in Lothian, which is the area around Edinburgh, and 3 community pharmacies in Tayside, which is the area around Dundee, sort of up on the east coast, really deprived area, lots of geographical challenges in that region, but really committed abortion care providers. And what we're going to do is have in these pharmacies, we're going to train them up. So the diploma of the Faculty of Sexual and Reproductive Health is kind of the standard qualification that general practitioners might get if they want to enhance their contraceptive knowledge, their reproductive health knowledge. We're going to provide that to pharmacists and train them, so free at the point of cost for them. We're also going to train them in how to insert contraceptive rods, the next one, into the arm. And we're going to give them some additional training in providing contraceptive injections, because while that is something that should be nice and easy, they give plenty of injections for the flu program, all this kind of thing. Conceptually, it's a little bit challenging for them. So we're going to try and support them in delivering and sustaining that. And also, this is all going to be hung around the idea of them also dispensing the telemedicine abortion medications following the consultation. So the idea being is that particularly in Tayside, the main hospital, the gynaecological hospital, is on the coast, but the region extends really far inland. So rather than women from this area, Angus is what it's called, the area, rather than women from Angus having to hoof it all the way across over to Dundee City, they'll be able to have their telemedicine consultation and then go to a designated pharmacy hub point to then speak to the pharmacist, get the medications that have all been pre-packaged and authorized by the doctors and the telemedicine service, and then have a chat with the pharmacist about what they would like to do. Would they like STI testing? Would they like, they've got problems with nausea? Do you need to get some medicine for an antiemetic? Would you like to have some contraception? You're not ready to decide? Well, why don't you come back tomorrow and then, or next week, and then you can see me here in the pharmacy. I'm already trained to do all of these things. So if next week you'd like to pop back and get an implant, I'll give you an implant next week. So that's the ethos behind this pilot. And why community pharmacies? Well, compared to some of the other maps that I've shown you of Scotland, every red dot on here is where there's a community pharmacy, and the big red dots are where there's lots of community pharmacies, and you can see them dotted around even in the places like Harris up here, these little islands, and as Orkney and things up here have got community pharmacies. These little bits that have got almost nobody living in them, there's community pharmacies dotted all the way throughout. So actually thinking about where we've got services, the community pharmacies are actually could be a really valuable resource for being able to connect people with medication abortion. And contraception more broadly, because that's what this project is going to be looking at as well, contraception and sexual health more broadly. And one of the things that we have in Scotland in recent times is the ability to provide people with the progesterone-only pill. So we use desogestrel, which I understand is not actually licensed, I think, in Canada for desogestrel on its own as a progesterone-only pill. But it's quite similar to drospirenone, which I think you guys have, except you take it every day. And it's very safe to use, very few contraindications. And Professor Cameron, who I work with, conducted a randomized controlled trial demonstrating a much higher increased use of any kind of contraception 4 months after emergency hormonal contraception when it's supplied with a 3-month supply of progesterone-only pill versus just giving people emergency oral contraception alone. So pharmacists are the main providers of emergency contraception throughout the country. So again, expanding their scope to include other kinds of contraception is feasible. And we have a randomized controlled trial showing that they can actually make a really positive effect on people's long-term contraception use by getting them to provide a short-term contraceptive method alongside emergency hormonal contraception. So that is kind of a fertile ground on which to build other kinds of contraceptive care. And it's now part of our national healthcare provision in pharmacies that they will be able to provide this free at the point of access to patients when they present for emergency hormonal contraception. That being said, and I have got just a couple more slides left, I'm sorry, I'm conscious of the time. So far, it's not working completely according to plan. So at the bottom line here, we've got the percentage of people who've had an emergency hormonal contraceptive consultation who then get this progesterone pill afterwards. So this is broken down by quarters. So Q3, end of Q3 is when the legislative change came in place that allowed kind of mandated pharmacists to do this. And you can see the sudden jump up to it being used, but these still represent just about 1%, 1.2% of all cases. And just to show it another way by Health Board, the dark blue lines are emergency hormonal contraception on its own when they're provided by pharmacies. And the light blue lines, which you probably can't see at all because they're very small, you can just see this one here, are when people have got emergency hormonal contraception and they've got a progesterone pill as well. Tayside that we're working with, they are proportionally the best at doing this at 1.8%. Lothian, where I work, are proportionally the worst at doing this at 0.9% of consultations. So there's a lot of work that we could do to enhance this and show and improve the access. And I think it's a real opportunity. And part of the SHARP project is going to be looking at all these different dimensions and then also thinking about them in relation to other forms of contraception. So we don't end up just doing a great study that shows that we can, in theory, make it work. What are we going to do about the implementation of this and the sustainability of this going forward? So thanks very much for listening to me this morning. I'm really happy to answer any questions if you've got any. We've got time for it.
Nicole, is there any questions in the comments?
Yes, Regina had a question. Is 12 weeks the common upper gestational age limit for medical abortion? In Canada, it is 70 days to 77 days for experienced providers per SOGC guideline.
Yeah, so for Scotland, again, the legislative difference between England and Wales and Scotland, it is, and we routinely provide medical abortion up to the 11 and 6. But as you can see from the percentages that are presented in some of the earlier slides, we actually don't have huge numbers going through that gestation because our access is improved with the medical abortion program that we have and the way that we've devised services. Still, most people coming through for a medical abortion are underneath 9 weeks gestation, but we have been readily and happily providing up to 11 and 6 in line with World Health Organization guidelines. And we don't really see more complications in that group, particularly when we provide them with an extra dose or 2 of misoprostol and a telephone advice. They get on really well.
Any others from the remote audience, Nicole?
No others, but I know some folks have just mentioned they had to leave to attend other meetings. So
sorry for running
off. No problem. Lots of kudos in the chat, and thank you so much. That was a phenomenal talk.
Any questions from the room? Yes, Wendy, go ahead.
Thank you, John. Just a super talk, and I think for our listeners to understand that the population in Scotland of 5 million people is very, very similar to our population in BC. So far, we don't have our latest abortion statistics for BC, but we have about the same rates, about the same numbers. But we aren't familiar, and I don't think we would say we've seen, perhaps even the opposite, an uptick of abortions since COVID. And I appreciate your explanation that perhaps contraception provision really dived, and particularly long-acting reversible contraceptive provision when things went to the much less effective and typical use oral contraceptives instead. In BC, we've had over the same period a very big push for helping people to access more long-acting methods of contraception, and I'm hopeful once we receive our results for these years that it will reflect the experiences we're hearing from clinics, that there just doesn't seem to be an increasing demand, even almost the opposite. Many of our independent service providers are now becoming full-service sexual health clinics and managing miscarriages and many other service opportunities, including enhancing their contraception provision, because there aren't as much demand for the procedural services now that independent providers are providing medication abortion. Well, we'll see how it turns out once we get the numbers, but hopefully we've been able to avoid that uptick probably related to a downtick in contraception access.
And I think it's probably also related to how we pay for healthcare and how people are reimbursed in the NHS. And there are not the incentives that used to be in place for general practitioners to be doing procedural long-acting reversible contraception. So an enhanced payment used to be in place for doing an IUD, it used to be in place for doing an implant. And that is kind of being, or rather I should say, those enhanced payments are in place, but do they actually meet the right criteria with the kind of spiraling inflation? General practitioners, we had an exodus of people leaving general practice, retiring, who had the opportunity to think, is this a good time to retire? Maybe they would have carried on for another 3 or 4 years, if not the pandemic, but actually they've said, okay, that's me calling it a day. And so we've had general practices close, and people then, we have a huge surge in the numbers of people that are registered with the remaining GPs. So it's becoming quite tight and very, very precarious at the moment. And secondary care and tertiary care services that we offer in the Chalmers Centre for Sexual and Reproductive Health, we provide lots of training to people, but we just drowning under the number of requests for care. And then how do we manage all the training? And I think we're getting, like many other places in the UK, we're now at the point where it's being realised and people are starting to invest in it a little bit more and talk about it a bit more. And we'd feel like we're maybe just about getting over the kind of hump of some of this stuff. But I think we're still going to see over the next year, 18 months, the effects of this on the abortion rate and what have you.
Well, thank you so much for an amazing talk. And I'm just conscious of the time and I see people scuttling off. So thank you so much. It was fantastic.
Thank you for the welcome to Vancouver. Thanks.
Yeah, it's been 30 people together.